Thank you so much. It really is wonderful being here and talking about something that's near and dear to my heart. One of the things that is a little bit disconcerting, however, is now when I begin talking about the pediatric of nursing history, how much of it I've lived. So, but with that aside, not the beginning of the presentation, but the latter part. The objectives that were given to me for today are to describe the evolution of pediatric nursing as a specialty practice discipline, discuss the historical events and policy and practice issues that have impacted the development of pediatrics as a nursing specialty, and finally, given national pediatric nursing education survey results, develop some strategies to strengthen the competencies in pediatric nursing practice. So that's a lot of turf to cover in 25 minutes. I'm from the Northeast. I talk fast, so here goes. So the very first charge was the evolution of pediatric nursing as a specialty practice discipline. And when I begin looking at this, one of the things, if you go back in history, that becomes very clear right from the onset, the subtitle of this presentation is Two Roads Diverged. Pediatric nursing really began on two very separate pathways. And in some ways that continues today, and I hope I will be able to make that case for you as I go on. If you go to the early history of our country, and I'm not going to go all the way back to the beginning of the 18th century, I will go back to the beginning of the 19th century. We were, for the most part, an agrarian society. People had lots of kids because they needed them to run the farms. But what happened in the mid-19th century is that we had major social upheaval take place as part of the Industrial Revolution. And we saw real shifts in populations and where they lived in the age groups and whatnot. And urban living became very much the norm rather than the exception. But cities were growing too fast, both here and abroad, and they didn't have the infrastructure that their populations needed. They had substandard housing, sewage ran directly down the street and into the streams and then contaminated the water, and then the cows drank the contaminated water, not the people too, ended up with TB, and then the milk from the tuberculin cows was sold back to poor mothers. And if you see in the bottom picture, it's a woodcut of what we call swill milk, which was milk that was from tuberculin cows watered down and then chalk added to make it look like real milk. And they were the kinds of things that were very common in the mid-19th century. The other picture on the screen is the accidents really just took off because there were just many more ways for children to be injured, both at home and in the workplace. Working conditions were abysmal. Children would go to work as young as 6 or 7, and we began to see dramatic shifts in mortality and morbidity. The infant mortality in the almshouses was as high as 97% within the first year of life. And the greatest increase in mortality in the whole population was in children and youths between the age of 5 and 19. Most died from accidents, and a lot of those were workplace related. But we also began seeing way more deaths associated with infectious disease, because when these infectious diseases hit the big cities, they ran rampant. As a response to this, Dr. West founded the Great Ormond Street Hospital for Sick Children in London, and it opened its doors on Valentine's Day in 1852. And listed below are the 3 aims that Dr. West set forth for his institution. The first was to providing inpatient medical care to ill children and advice to mothers of sick children who weren't admitted, promoting the advancement of medical science, and employing the hospital as a school of education and training of women in special duties of children's nursing. What is particularly interesting about this, and this is what he said, the instruction of young women in the care and management of sick children sets the pattern for the development in sick children's nursing for the next 100 years. He said that in 1854. Now, if you're good with your history, you will realize this is exactly 3 years before Nightingale trekked off to the Crimea, and a full 10 years before she opened the first Nightingale School of Nursing. So pediatric nursing actually precedes, and nursing education precedes what we consider the era of modern nursing. This noteworthy plan, however, did not meet with immediate success, and in order to improve the recruitment and the quality of the nurses, Miss Wood was named as the first superintendent of nursing, and she began a 2-year training program, and there is Miss Wood in this slide. Her writing said that sick children require special nursing, sick children's nurses require special training, and she insisted that her nurses keep the child well amused by occupations and interest. And from my reading, that's probably the first recorded record of play therapy or therapeutic play. From that, however, Florence Nightingale did not exactly agree with this view, and you have to know her little hospital was just actually just several squares over from Great Ormond Street. But she wrote, "Whatever you do, do not have the children's wards in a general hospital, but mix them up with the adults. For where the adults are mixed with them, the woman in the next bed, if the patients are judiciously distributed, often became the child's best protector and nurse." So if you were sick, you got to sort of pay your own way by taking care of a sick child. Fortunately, pediatric nurses had a better world vision than that and moved forward in that. The advent of children's hospitals in the United States began with Children's Hospital of Philadelphia, which opened in 1855 in cooperation with Great Ormond Street. For those of you who are interested in finances of children's hospitals, just the first year they had 12 beds, 67 patients, and no fatalities. Their receipts were $4,406, expenses $1,966. So they ended up with a surplus of $2,410. So anybody at Children's Hospital in Philly, you can take those numbers back. The second hospital then opened in Boston in 1969. That was Children's Hospital of Boston. That building still stands. This wasn't the original. We don't have cows on the front lawn any longer. San Francisco Children's Hospital opened in 1880, and Floating Hospital for Children in Boston opened in 1894. By the end of the 19th century, virtually every major urban area had its own children's hospital. This is important because most of pediatric nursing then became embedded in these children's hospitals. I just wanted to show you these few pictures. These are actually from Floating Hospital, which is now part of Tufts. The first recorded pediatric nursing research was done at Floating Hospital. It was on infant feeding. And the bottom picture is where children were getting vitamin D therapy. They would on the ships, and these were all nursing research studies, and they were such quality that they were noted by Abraham Flexner. You may know the Flexner Report, which changed medical education. All right, so you had this one path going down through the hospitals. The other path, however, was clearly rooted in community health. And public health was initiated by Lillian Wald in 1883 in New York City with the Henry Street Settlement, and it was to care for the sick poor, and the involvement of community activists also complemented nursing's contributions. And from her work, one of the projects that came out of that was New York was really trying to curtail the number of sick children in school and the absentee rates. And they hired a bunch of physicians, and in short, that exercise was pretty abysmal because what they weren't doing was keeping kids from just going home and infecting everybody else and teaching families about how to care for communicable diseases at home. So Lillian Wald, in 1902, hired Lena Rogers, who was the first school nurse at the country, and really turned the absentee rates around and was really the founding mother of school nursing. Public health nursing then began taking off across the country, both in certainly in major metropolitan areas. You'll see the public health nursing climbing over the tops of the tenements. It was easier than walking all the way down and walking back up. And also in rural areas such as frontier nursing, and also in the deep south. So there's a variety of places where public health nursing really took over the primary and well child care and family teaching of mostly lower socioeconomic families. Now, let's switch to early pediatric nursing education. As I mentioned, this really began in the hospitals. The first school of pediatric nursing in this country was in Boston in 1878, and the second was the Ingersoll Training School at Children's Hospital in Philly in 1895. And one of the reasons that these schools opened was there was a real need for trained manpower. And hospitals up until that point were not taking children with communicable diseases because they were afraid it would race through the entire hospital. But at that point, they began admitting children with communicable diseases because they don't have enough manpower to handle those. So there was a great amount of attention placed on infectious disease and so forth. The first incidents of pediatric nursing that began appearing as a separate entity in text that I could document was 1886. And then pediatric nursing education firmly became established when pediatrics became established in medical practice right around 1900, and then even more so after the Flexner Report. Now, some of the advances in nursing education. In 1917, the standard curriculum for schools of nursing stated that classes on pediatric nursing were to include lectures on social issues in psychology, infectious diseases, orthopedic and surgical conditions, and information about infant feeding and child development to give a, quote, good sound basis for later work in connection with milk depots, baby welfare, school nursing, and other fields of work where nursing and skill in children's nursing are of essential importance. Following that, in 1923, was the Goldmark Report, which was commissioned by the Rockefeller Foundation. It was also called the Commission for the Study of Nursing Education. And this report had pretty harsh criticisms about the standards in nursing education in general, and particularly around pediatric nursing and community health nursing, and talked about or public health nursing, and how about the standards for public health nursing really weren't at all well developed. It isn't of accident, however, that a couple of the major writers of this report were the folks that founded the Henry Street Settlement House. So, moving on from that, children really became much more of an interest in general. They were no longer just treated as property of their parents. The first White House Conference on Children was in 1909. The Children's Health Bureau opened in 1912, and then in 1921 through 1929 was the Shepherd-Towner Maternity Infancy Act. This is important because this was the first time that it allowed many nurses to be employed in infant welfare centers, maternity centers, and provided educational classes in primary care, if you will, for mothers, lay midwives, and mothers' helpers. This act was only in place for 8 years, but really set the foundation for much of what we saw from the Maternal Child Health Bureau today. There was also a second White House conference in 1919, and the purpose of that one was the first one was for dependent children, and the second was a comprehensive report on the state of children's health. In 1935, the next major piece of legislation that affected child health care and pediatric nursing was the Social Security Act, or Title V, and maternal child services, and what we used to know, if you're old enough like me, as crippled children's services. So if you were practicing before 1981, you would remember that crippled children's services began as part of that act. And again, that opened many doors for pediatric nurses, but also helped shape the content that needed to be in pediatric nursing curriculum. Following on up from that, the next major in the mid-40s, and this isn't pediatric nursing education specific, but one of the things that happened is a lot more of nursing education began moving into universities, particularly post-World War II. And so that really laid the groundwork early on for advanced practice in pediatric nursing. But in 1965, Title 19, or the Social Security Act, which was provided both Medicaid, monies for Medicaid and Medicare, was really the first comprehensive federal entitlement for child health. However, and this is really important as we go down this little trajectory, unlike Medicare, which is fully federally funded through a variety of mechanisms, Medicaid is a state and federal partnership. So it's substantively and structurally different from Medicare, and if you track Medicaid, first off, it varies significantly state by state. I tell my students, if you've seen one Medicaid program, you've seen one Medicaid program. You know, they just do not generalize across. And the other thing is we know over time is when there's cuts in monies and revenues, they first happen in Medicaid programs. So let's take out the children and the poor first has sort of been the standard. And I think we need to really think about that as we move into the new health care legislation down the road. The next major, and I'm going to talk about some of these a bit more generally as we go forward. Don't you love this picture of Loretta Ford? This is the earliest one I could find. This is 1971. I'm sure she'd die. But Loretta Ford and Henry Silver really through a social engagement began talking about how they could improve the care of children from poor communities who were truly underserved. And that was really the birth of the pediatric nurse practitioner movement. And it got started with one nurse who had returned from the Peace Corps and probably didn't quite know what she was signing up for. And from there, all we know about pediatric nurse practitioners moved forward in that. I put the other slide up, Making Room at the Clinic. This is a text by Julie Fairman, and it really does talk about the early nurse practitioner movement, particularly to pediatrics. So I'd put that on your reading list. Now, the Great Society, if you remember, really began with Lyndon Johnson, and then many of the initiatives that started during his presidency then carried on over through the early Nixon years and beyond that. So from 1965 right up until about the year 2000, we had a number of federal laws and initiatives that really were not pediatric nursing specific, but paved the way for why we needed a pediatric nursing workforce. Head Start most certainly is one. WIC programs, and often nurses are employed in sites where WIC programs are embedded. Early pediatric screening, diagnosis, and treatment programs were enacted, and again, many of these are conducted by advanced practice pediatric nurses, and probably many of nursing students have participated in EPSD programs. Supplemental security income for children with disabilities was enacted. In 1981, there was a major shift at the federal level from monies from the Crippled Children's Fund, and MCH monies were moved into MCH block grants by states, and states were allowed to use those monies in different ways. In some states, pediatric nursing and pediatric nursing directly benefited. In other states, not so much. So it's a very state-specific. But there were mandates that came out from the federal government along the way for how some of those funds should be used. Healthy Start, or the Emergency Medical Services Program for Children in '84, Healthy Start in '94. And then if you remember, when we had temporary aid for need for families came in '96. That was the first time Medicaid and AFDC, aid for dependent children, was decoupled. So it used to be if you were on AFDC, you were immediately, your children were enrolled in Medicaid. When that became decoupled, we were watching lots and lots of children fall through the cracks. And with that, the state children's health insurance program was put into place in '97 and was reauthorized 2 years ago now, I believe, and expanded. It's been a highly successful program. The reason why all these initiatives are important is these all provide some infrastructure upon which pediatric nurses and settings can practice and be educated with. So it really does underscore the importance of the federal government and the greater societal needs for where we're standing right now. I have to mention HRSA. Many of us in this room, and for a quick show of hands, how many of you have been educated on HRSA money? Went to a nurse practice? Lift your hands high. I mean, this is huge. The Division in Nursing had funded many and still does, many nurse practitioner programs, but there was never a special call for pediatrics. There was for nurse anesthetists in the Division in Nursing. And also, if you went to the Division of Population, that's not quite the right name, but under the Title X monies, they funded nurse practitioner programs for Planned Parenthood and women's health care nurse practitioners. But there was never a slot specific for pediatric nurse practitioners or family nurse practitioners. So we were always at the table vying for the same monies that other programs that were often much larger were vying for at the same time. But the contributions of HRSA through the Division of Nursing, Division of Population, the MCHB are just huge. I would be very remiss if I didn't talk about the pediatric nursing professional organizations. They were interdisciplinary groups. The best known started in 1965 and unfortunately folded in the late 80s or early 90s. That was the Association for Care of Children's Health. Some of you may remember that as the Association for Care of Children in Hospitals. And then on down, we had independent specialty groups. But I think what is critical to us is the first general pediatric nursing group did not begin until 1990. That is way later, guys, than most of our most other specialties. And there are other subspecialty groups within pediatric nursing. And that has led to some fragmentation that we're still trying to overcome. And it's one of the great reasons for this meeting today. Pediatric certification and licensure is 1977, and then for the first PNP certification, and then 89 for general pediatric certification. But more importantly to our discussion is licensing exam changes to the NCLEX, where there was no longer a specific exam for pediatric nursing. And that's what's allowed a lot of the pediatric nursing educational programs to cut, reformat, or whatnot, how they handle that part of the education. And then last year, the Patient Protection and Affordable Care Act, which gives us all kinds of avenues to move forward. Now, the second task I had was the impact of the historical events on the development of pediatric nursing. And if I had a crystal ball, or we had a crystal ball 20 years ago, we would have gotten it all right and we would have had a perfect house. We did not have a crystal ball, and perhaps our house might look a bit more like this. There are places where we definitely need to shore up some of the problem areas, and there's other areas of terrific strength. So, using a SWOT analysis, my MBA hat on, strengths and weaknesses, opportunities and threats, I want to do this from a historical perspective. Remember, strengths and weaknesses are internal to the profession. The opportunities and threats are more external. So when I pulled out some of the strengths, some of the things that really emerged from our two-pronged history, family-centered care, care coordination, medical homes, not a term I love, but that really is setting the stage for a lot of adult care now, most certainly symptom management, pain assessment. Pediatric researchers had that down way before our adult colleagues, managing prematurity, school health, and of course, pediatric nurse practitioners is the beginning of the NP movement. Some of the weaknesses, a lack of a central professional identity. You will hear people talk about, I'm a PNP, I'm a NICU nurse, I'm a school nurse. People don't talk about themselves very often as being a pediatric nurse, particularly if they're in community settings. We have lack of integrated partnerships. Remember, most of the children's hospitals in this country are freestanding. They may be associated with academic medical centers, but not necessarily a part of. And that creates some structural issues. And a huge weakness is the change in focus of MSN programs, and I'll talk a bit more about that. Lastly, pediatric nursing is the most costly of the subspecialties within nursing education to educate. Many hospitals, for example, require a 1-to-6 ratio for clinical faculty, where adult hospitals require 1-in-10. It doesn't take much to do the math to see why people do not want to be hiring, schools who are on very tight budgets do not want to be hiring extra clinical faculty. And yet, on the clinical side, I think we'll all be clear that with the acuity of kids in hospitals today, that's needed. The threats, NCLEX. This is, as I mentioned before, this has been a huge threat to our content, the aging population. Remember, if you're old, you vote. If you're a child, you don't vote. Many areas of practice were, but are not now, the strict purview of pediatric nursing. Specifically, immunizations used to be pediatrics. I used to tell my students in the dark ages, just tattoo it on your forearm. This is before tattoos were popular, because the immunization schedule never changes. Have you seen the immunization now? You know, every couple months, it changed this week, actually, again, with the new HPV standards, but they're whole grids now, all the way along. It used to be conditions like CF and whatnot were only pediatric conditions. They're not anymore because we've been so successful in what we do that those children are living well into adulthood. Some of our opportunities that we've seen in the past that I haven't had much time to talk about, but academic practice partnerships. One of the nice things that happened in the late 90s was with some of the fiscal structure rearrangement of some hospitals. They had extra money they had to spend on community activities, and there are a whole handful of endowed chairs that are linked to children's hospitals with universities that came out of that. And that's a very vibrant type of partnership, unlike other types of joint appointments. The new CTSA grants also provide tremendous opportunities for engagement across from acute to primary care. Also, we are embracing the changes that are occurring in hospitals, magnet status, improved programs of clinical inquiry, nurse residencies, and this is huge under the current Patient Protection and Affordable Care Act. We're going to see a lot of children's hospitals become much more vertically and horizontally integrated healthcare systems, which is going to open the doors for, I think, for a lot more pediatric experiences. So lastly, you realize each one of these sections is getting shorter, so I'm not too much more over my time. My colleagues are very kind. Strategies to strengthen, I will suggest 4, and we hope these are provocative. We need to be proactive. Every action, there is an equal and opposite reaction. We've seen some of the mistakes we made in the past, and we're paying for some of those. There's strength in numbers. We need both intra and interdisciplinary collaboration, not only professional collaboration, but also with community partners and advocates. Back to the future, I talked about integrated healthcare systems, but I want to talk ever so briefly about advanced practice nursing. In the mid-90s, the clinical specialists in hospitals were being laid off left and right because they couldn't show that they were cost effective or their outcomes. The reason PNPs could was that everybody else was looking at us doing the research, not so much that we did so much of our own study. I was directing a nurse practitioner program then, and I could share stories with how awful this was. I am very concerned now about the DNP curricula as they go to the same route, that if we don't, nurse practitioner programs, for better or worse, were always highly prescribed. If we don't have really high standards in these DNP programs, across programs, we are setting ourselves up for, I think, as we move into the new healthcare legislation, for the same type of major fall. And lastly, we need to shed the cloak of invisibility. And with that, I'm going to turn the future over to my colleagues. Thank you very much.